If the last 5 diseases that we've discussed so far are causing you to be a bit confused, don't be surprised. They definitely sound similar and have some overlapping features. Hopefully, what we're going to do here is to give you some pertinent lab values that will help you wean down a differential that you're developing as you read through a clinical scenario. Your major labs for bone diseases will be serum calcium, phosphate, alk phos, and PTH. These will help you differentiate what's going on. First off, 2 of these diseases have no lab abnormalities at all. Do you remember which 2? Good. Osteoporosis and osteopetrosis. Sometimes in osteopetrosis, you may see decreased serum calcium. Similarly, Paget's disease has only 1 lab abnormality, and that is, do you remember? An increase in alkaline phosphatase. These are not diseases that are caused by inappropriate hormonal regulation of minerals. They are simply inherited or acquired defects in bone architecture. The next 2 diseases, however, are actually defects in bone mineral metabolism. In osteomalacia and rickets, patients have a deficiency of what vitamin? That's right, vitamin D, which causes them to have a low level of calcium. This will then trigger an increase in PTH. However, in doing so, this drops the phosphate levels, because PTH is also known as phosphate trashing hormone. Also remember that in this disease, alk phos is increased. Osteitis fibrosa cystica is the name of the bone disease that accompanies hyperparathyroidism, as you'll remember from our endocrine pathophysiology. There is primary and secondary hyperparathyroidism. In primary hyperparathyroidism, you'd expect your initial lab value, the PTH levels, to be increased because that's the basis of the disease. This unchecked increase in PTH in turn causes an inappropriate increase in the levels of calcium and also a loss of phosphate. Additionally, we will see an increase in alk phos due to increased bone turnover. But what is dysfunctioning in secondary hyperparathyroidism? The kidneys, which may be failing and causing chronic low calcium levels. Because the kidneys aren't doing their job, you would also see high phosphate levels because PTH can't trash phosphate in the kidneys. These are the key lab values to differentiate between primary and secondary hyperparathyroidism. Also, in secondary hyperparathyroidism, you'd obviously have an increase in PTH. In both primary and secondary, alk phos is increased. In hypervitaminosis D, both serum calcium and phosphate will be increased. This makes sense because vitamin D encourages the absorption of both these elements in the body. The alk phos is generally normal, while the PTH is decreased. This happens because the higher levels of calcium are downregulating PTH production. Okay, we're going to discuss primary bone tumors, which is not an incredibly high-yield topic. There are a couple that we'll point out as being fairly important. Let's turn our attention first on the benign primary bone tumors. There are 2 tumors here that have very classic presentations. Giant cell tumors are the first high-yield tumor in this group. They occur in the epiphyseal end of long bones, so think the distal femur and proximal tibia most likely. They most commonly occur at 20 to 40 years of age, which is one of its distinguishing characteristics, as most other tumors tend to be in a younger population. They are locally aggressive, and an X-ray will show the double bubble sign or soap bubble appearance. And histologically, they'll show spindle-shaped cells with multinucleated giant cells. Do you see the multinucleated giant cells? Giant cell tumors express high levels of rank L, which does what? Well, rank L is a ligand that induces the formation of multinucleated osteoclasts. One more classic fact to know about giant cell tumors is that they're more likely to present in females. The next tumor we'll discuss is slightly lower yield, but has a couple characteristics that should make it easy to recognize if you're asked about it on your boards. This is an osteochondroma. Now, what does the name indicate it's composed of? Very good, bone and cartilage. It is in fact the most common benign bone tumor and is often seen as a piece of mature bone with a cartilage cap, usually in men less than 25 years old. It commonly appears in the metaphysis of bones. It grows out of the bone and presents as an exostosis. This type of tumor can malignantly transform to a chondrosarcoma, though this is rare. And now we'll move on to malignant tumors of bone. These are high-yield tumors that you'll need to be able to recognize for step 1. We mentioned 2 important malignant neoplasms, but you should also know about multiple myeloma. Multiple myeloma is actually the most common, and due to its relation to B-cell physiology, will be discussed in the Hem/Onc lectures. The second most common malignant bone tumor is osteosarcoma, also known as osteogenic sarcoma. Now, who gets osteosarcomas? Well, it most commonly occurs again in the young age group of males, aged 10 to 20, but there is a second peak above age 65. Like the osteochondromas, osteosarcomas are also found in the metaphysis of long bones. This MRI shows the tumor arising in the metaphyseal region of the left humerus. Now, what do you need to know about osteosarcomas? Well, you need to know what they look like on an X-ray and predisposing factors for osteosarcomas. Classically, on X-ray, osteosarcomas are described as appearing as Codman's triangle or the sunburst appearance. These terms radiographically describe what is happening pathologically in the bone. The tumor cells are growing underneath the periosteum of the bone so fast that the periosteum is being lifted off its normal plane of growth, which creates the triangle or sunburst. This classically describes osteosarcomas. The second thing you should remember is why people get osteosarcomas. The list is long, but worth remembering. It includes Paget's disease, bone infarcts, radiation, and familial retinoblastoma. Do you remember from the pathology chapter which gene is commonly lost in retinoblastoma that is also frequently lost in osteosarcoma? That's right, RB1. With the first 3, you can imagine reasons for bone to be damaged and more prone to be dysplastic. Treatment is aggressive for this malignancy. Patients usually get multiple rounds of chemo, followed by en bloc resection. We do everything possible to shrink the tumor and salvage the limb. Flash quiz. What is the classic finding for osteosarcoma on X-ray? Codman's triangle, or the sunburst pattern of the bone. The second malignant tumor to know is Ewing sarcoma. This is a type of tumor that's called a small blue cell tumor. This pathology shows sheets of small round blue cells. These are in Homer-Wright rosettes. Do you recall what other tumors are described as small blue cell tumors? Neuroblastoma, medulloblastoma, retinoblastoma, and Wilms tumor. Like all other tumors in this family, Ewing sarcoma is very aggressive and presents often with early metastasis. Now, where does it metastasize? Usually the lungs. However, it will respond to chemotherapy, which is life-saving for patients. It can happen in a variety of bones, usually in the diaphysis of long bones, but also in the pelvis, scapula, or ribs, truly on most parts of the body. There are 2 classic aspects of this disease to remember. The X-ray catchphrase is onion skin appearance in the bone. You can remember this with the memory aid, Ewing's and onion rings. Another important thing to remember is that it occurs as a result of an 1122 translocation, which results in a translocation and fusion of the protein EWS-FLI1. There aren't any other malignancies in this section with a similar translocation, but in the Hem/Onc chapter you'll see at least 3 more, so be sure to keep this straight. If you follow basketball, think 11 plus 22 equals 33, which was Patrick Ewing's jersey number. Flash quiz. Where do osteosarcomas originate? In the metaphysis of long bones.